Recording in progress.
Oh, okay. We're right on time. Thank you for all the early birds that have signed on. I think you could still see Leona. Leona's my partner in these Empowering Patients program. And I want to thank Leona right off the bat. And you can thank her as well in the chat or just in spirit, because she's helped me really organize this over 6 years.
Something like
6
that.
years? Yeah, 6 years. We're losing count. Of course, this is our second year doing it virtually. And the big topic today is one of my most important relationships, my relationship with every patient, and your relationship with your family doctor or any healthcare provider. So I hope I'll be sharing some really practical tips that you can use with any encounter with nurse practitioners, physicians, anyone in the emergency room, with nurses that you're working with as well, because we're all kind of partners in your well-being. So Leona will tell me if my voice dies out because I'm still at the office, and I'll tell you the life of a family doctor so you can see the other side of things. And I'll give you some behind the scenes look in the doctor's office. So it'll be lots of fun and interesting. So this is about the patient-doctor relationship, and I always put the patient first. That's why it doesn't say doctor-patient, because that's the focus, your well-being, and making the most of every medical visit and every encounter. So why are we here? Leona and I are here because we care about our patients, but we also care about our community. And this is really our outreach as part of the Burnaby Divisions of Family Doctors, the family doctors that look after patients and everyone within the Burnaby community. And of course, we have patients throughout all of Greater Vancouver. And we care about the future, and you're a big part of that as well. So I just want to remember that we're all part of the same community, and we look after the well-being of everyone else, our neighbors, and even those that we don't know that are across the street or down the street. As doctors, we care about our patients, but we care about our community as well. So I always start our talks with just asking, what is healthcare? And who really provides most of your healthcare? And you're right, it's not me. It's not just healthcare professionals, it's you. You're most responsible for the things that will keep you healthy, and you meet the challenges, and we're here to support and guide you. And that's our job. So I always think of 4 foundations of looking after ourselves. The first is what we do, physical activity. That was our topic last month. We were doing our walk with your dog. How you feel, emotional well-being, and that will be one of our upcoming talks as well. How we connect, healthy relationships. So the 4 of those: what do you eat, what do you do, how you feel, and how you connect. And then what do we need for good self-care? We need support to achieve your personal goals, and we need good patient-doctor communication. That means we have to speak in a language that our patients understand, and we need to listen first, and work from your goals, not the doctor's orders. So remind your doctor if he's giving you orders, where she is. And of course, with the patient-doctor relationships, there are infinite varieties, like with all relationships and all marriages and all families. Everyone is unique, but we have one common calling, and that's your well-being. Otherwise, we wouldn't be in this profession. But of course, we have personalities too as well, and doctors are people as well. And of course, we're imperfect and we have our own quirks. And hopefully you don't have a quack with lots of quirks. Again, we're all different, but we all care in our own special ways. So I'll talk about how doctors get stressed. As you can see, I'm still in the office. I've actually stopped seeing patients around 5:30 today, but I was actually still working on all the tasks that are coming in through my computer, electronic medical record. So typically we're doing non-patient face-to-face work, like we're doing lab results and doing reports and filling out forms at least 2 hours every day, usually averaging 2 or 3 hours in addition to the usual office day, which is usually 7 or 8 hours, not counting deliveries and doing rounds at the hospital or nursing home visits or house calls. So it's a very long 70-hour week, but a lot of it is a little bit frustrating just dealing with all the tasks that are coming in. So I've I've been here since 5:30. I still have probably another hour of tasks to do once I finish with our webinar together. So I'm sure you'll be thinking about me while you're going to sleep tonight. So we get stressed when we run behind. And as you know, that happens a lot when our patients are upset, or we have really complex cases, or very sick patients that we're really concerned about. And doctors too can have personal problems, especially if we're not looking after our own stress, if we get burnt out and have problems at home and not looking after our own health. And there's a bit of work we do behind the scenes as well. So I'll give you kind of a quick look. So doctors don't love forms. We have a lot of forms, and there's many different varieties. Medical legal reports, like for ICBC cases, they can consume several days of work, like giving up a weekend to complete a 20-page letter for a patient, because it has to be so exact and precise. And we have to write it, in this case, in quite a different role. When we're completing forms and we're completing medical legal letters, we're not supposed to be. Our usual role is being your advocate. We're supposed to be objective. Otherwise, they might toss out the letter if it appears to be biased. But in reality, as a family doctor, we're really biased towards you in real life, and we are here as your advocates. We have to apply for, on patients' behalf, for drug coverage with pharmacare and with extended medical plans. And usually that's quite complicated, and those take quite a while to do. And of course, the usual reviewing of test results, x-rays, MRI reports, consultation letters from different specialists, and the lab results. When you go to the lab, we'll get a bunch of results coming in a little bit at a time. So that's our numerous tasks popping up onto our screen. I always joke with my colleague, Dr. Barr, friend and colleague who sits next to me. I'd show you my whole office, but my desk is a messy one. Dr. Barr's is a very neat one, because that's just the way he is. And of course, we get really busy with interruptions, not just from patients, but from pharmacists and from the hospitals and from specialists and other allied healthcare providers that are calling in to talk about patients. So although we have an appointment schedule, it's frequently interrupted throughout the day by all these complications. So sometimes we do get stressed. And as I mentioned, there's a lot of non-face-to-face time that you don't see. We call it the administrative burden. And I've noticed in the past 30 years, it's astronomically increased. And actually, it's even more difficult with computers than it was before. So when I started practice, I used to get the lab results on paper from the Life Labs that were, or BC Bio that was just downstairs from us. And I'd get the radiology x-ray reports on paper in my hand, would be dropped off at the end of the day from Brook Radiology, for example. And I could probably go through all of those in 15, 20 minutes. Of course, that's not counting forms and other things, but just reviewing the tasks is usually a 2-hour task, 2-hour marathon every day at the end of the day's work, or after we get home, after family goes to bed, after we've had dinner. That's something we're working on. But there's a good reason why I signed up for this, why I'm a family physician. I thought about pediatrics and psychiatry and even surgery when I was in undergraduate medicine. And then even as a intern, we were interns in a type of residency called a rotating internship, where we went through all the specialties. For me, it was in Victoria General Hospital, to get a taste of every specialty. And then after that rotating year, we can go into family practice or go into other residencies, including general surgery or pediatrics or psychiatry. But I decided to do locums, like filling in for other family physicians in the Victoria area after I graduated and finished that internship. And what I really loved about family practice was the connection with the patient. So if I was doing a locum or covering for a doctor away for over a month, I would see some of those patients multiple times and really get to know their stories. And that's what I really fell in love with, the patients and their stories, and how a family physician knowing you over a long period of time becomes part of that story in a positive way. And we can shape you and help you achieve your goals in a really positive way. So this is a hidden view that patients never see in my office. So my medical office assistant, Christina, greets patients. She opens the windows in the morning. Patients are looking in from the other side of the window, but on the inside, there's a little strip to always remind us that we treat every patient as a friend or a family member. So when I see a patient, I want to give them the same level of care that I would expect for a best friend, or one of my kids, for my wife, or for my own dad. So I refer to the same specialist, do the same tests, and give the same degree of thought and consideration I would want for a family member. So that's our golden rule of medicine in my office. And I know my staff treats my patients the same way, and they really appreciate that. So some of my patients, most of my patients don't even know about this. It's kind of hidden away on the other side of the counter and they never see. So just a little sneak peek in my office without the patients in it. So we've been treating a lot of patients virtually. So a lot of my patients aren't familiar with the office anymore. In our lunchroom, this is behind the scenes too. So this is our lunchroom, but I put up some whiteboards and bulletin boards just to kind of inspire our staff as well. And you'll see on that top strip above the two boards are just reminders of why we're here, why we are doing family practice and not some other specialty. So I'll show you some photos of these reminders that we have. We really think of family practice as being unique among all the specialties in medicine because we treat the whole person, not just the conditions or the different parts or body systems. And in family practice, we don't treat disease. We care for the whole person. So disease is only seen in the context of that whole person's life, how it's affecting them and how they want to manage and treat it and their own personal priorities. And as I mentioned, we're advocates for our patients. So we're advocates for our patients to meet the challenges of their lives, and we're their advocates in the healthcare system as well. And we really do our best to make sure they get the care that we would want for a family member. And in family practice, we empower our patients to transform their problems into goals. So this is something that I have in one of my exam rooms, to think of their problems, consider them, but turn them into goals. And then that helps us lay out a plan to take those steps to achieve your potential. And of course, telehealth has really transformed how we're delivering care. So there's a lot of benefits and limitations, of course. So many of you haven't seen a physician in person for over a year and a half. So we try to manage what we can and to preserve safety. Some patients have really enjoyed the telehealth, either phone calls or video visits, because it's quite convenient. Patients can do it from their home. I've had some patients answer their calls for an appointment at the appointed time, but they're in the washroom at that time. And I usually try to reschedule those appointments, but a few have actually stayed on for the whole appointment in their washroom. I guess that's their most private place. And a lot of patients that live a bit further away, it prevents them from having to drive in, to park, or to interrupt a school day or a work day. But it does have some limitations. And one of them is it's not that great for diagnosing a lot of conditions. If you have an injury, you can only find out so much about the history, but sometimes we do really need to do a physical exam to make a proper diagnosis. So that's why it's really important for physicians to be safely seeing the patients in the offices again. So most likely your family doctor is doing a combination of both. And we're doing more in-office visits as more people are wearing their masks and having had their COVID vaccines. But even if you haven't had a COVID vaccine, do inform the staff. That should not be a reason why we cannot see you in person in a safe way. We just take precautions so that there aren't a lot of people in the reception area. So we try to space patients apart, and we wear the protection masks, goggles, and gowns if we need to, as appropriate. But the current standard now during the pandemic is that in every medical clinic and in the hospital, all patients, as well as all staff, including physicians, have to wear the medical mask. So that's a bit of a challenge and a bit of a reminder, but I think most of us are getting used to masks at this time. So having had the vaccine or not the vaccine, we would still look after your care. So you should still expect the same standard of care from us, but we are taking precautions as well. And of course, the other challenge of COVID has been information overload. That's why I'm very thankful that I've had the opportunity to talk to patients when they have concerns and safety about their health and the risks and benefits of vaccination. So I've been quite happy to have the conversations with my patients, and vast majority have decided to choose and get vaccinated and be protected against COVID. And some other major challenges in our relationship is, number one, access, finding a family doctor if you don't have one, waiting for an appointment, and we do our best to accommodate patients and see things that need to be seen as soon as we can. The challenge of time. So we often have, as human beings, lots of problems going on, but sometimes not enough time. So I have some tips on how we can organize that together. Sometimes it's a language that we speak, and it doesn't mean that we're not speaking English or another language. It's our medical, technical language. So we have to speak at a level that's understood by the most important person in the room, and that's you, the patient. So I'll give some tips on how to navigate that concern, and how to be your own advocate if you're with a healthcare provider and you don't understand what he or she is trying to communicate. And finally, the old idea of doctor's orders that I turn around to actually make it the patient's goals. So really, you're in charge, and we're here to support you on your choices. So we'll walk through each of these. So to find a family doctor, fortunately, we have the Burnaby Division of Family Practice. And if you're outside of Burnaby, there's a community division of family practice in Vancouver, Surrey, and all the major centers throughout BC. And each of them is tasked with trying to attach patients that don't have a family doctor. So if you're part of the Burnaby community, contact the Burnaby Divisions of Family Practice. We actually have dedicated staff, attachment coordinators that are linking up patients that don't yet have a family doctor to new young doctors that do. So I was pleased to see there's a number, I believe there's at least 4 family doctors and a nurse practitioner that are soon to be coming on board in the next coming few weeks or months. So although there's a waiting list right now, I think once they're up to speed, they'll be able to see a lot of people and give them the care that you deserve. So check with your local division of family practice, and for Burnaby residents, it'll be our Burnaby division. So why is there a wait in the doctor's office? Don't I have an appointment, and how come there's a long wait? In my office, we really strive to have a reasonable schedule with some flex time so we can fit in some of the extra calls and prescription renewals during the day. But there's a lot of things that make things unpredictable. One is we're all patients at some time, and our lives are complicated, and people have a complex of many different things going on, especially if you are dealing with chronic conditions. And as we get older, there's more things to deal with. So that's kind of the nature of life and the nature of our work. There are a lot of interruptions. For example, today I had 5 major interruptions, discussion with the hospice that's looking after one of my patients at Burnaby Hospital. So communicating with the family and talking about the patient's care. If we have patients in hospice, we need to deal with those calls right away. And sometimes we need to speak directly with a pharmacist, something different from prescription renewals. And I had one patient that was brought in from a nursing home that needed a lot more time to work through all her problems, as we hadn't seen her for some time prior to the pandemic. And then there's the unexpected need for counseling. So we can't restrict that visit just to 15 minutes when we suddenly find out that someone has lost a loved one and they need our support right at that time. So these are things that happen pretty well every day, and you can't schedule when they're going to pop up. So thanks for your understanding, and sometimes we can't predict things. I also still do deliveries, and my patients have always been understanding when I have to disappear at a moment's notice for several hours to deliver a baby. And my staff is really good trying to explain things to people. Fortunately, with about 40 or 50% of our appointments being by phone, it's getting to be a little bit easier to reschedule those. But it's really hard to run out on a patient that's just waiting in the reception room ready to be seen next. But the patients are never really upset when I talk to them later. They always ask, was it a boy or a girl? Because that's one of the things we celebrate together as a community. And then again, time. So many problems, but so little time. And it's that list, that complicated list of problems that we have. You may have heard in a few years ago, the college had to send a notice to doctors to say that they can't put up a sign that says you can only bring one problem per visit. Doctors kind of struggle, especially family doctors, because sometimes a patient's list is really, really long and not really manageable in any, even in less than 30 minutes. But it's really important to bring your concerns to the doctor, because we have our priorities as well for your health, and to kind of sit down and negotiate at the beginning of a visit to see what we can manage today and create plans on how to manage other problems if we don't have time during a single visit. So I'll give some tips about the list, which to many doctors is a 4-letter word, but it's just the nature of being a human being. So to prepare for your medical visits, I think it's really important to make your list of the important concerns that you want to discuss with your healthcare provider. But it's really important when you make the appointment to share that list of concerns, all of them, with the staff. Our medical office assistants are healthcare professionals as well, and they share your confidence. So even the things you might be shy about, please do your best to share it with the staff. It actually helps us prepare for certain kinds of visits that require extra information, like ICBC, motor vehicle accidents that require a little bit extra information and background, and work safe or work injuries visits that require some paperwork to fill up ahead of time. And also if it's something that requires special preparation, like a pap smear or a complete physical exam, we need to schedule enough time in to be prepared. So do share that with the staff so that the staff can schedule appropriate time and make sure that it could be dealt with by the doctor at the same visit. And that list we should review when you come into the office and at the beginning of the visit, and do bring a pen and paper. Or if you're really good with your smartphone, you can bring that along too, because it's always good for both of us to keep notes. We're keeping notes as well. And I usually, if I have a number of things I like to share with the patient, I usually try to write it down so that none of us forgets. So one of the keys, pen and paper, so you can write things down. And if there's a word that the doctor uses, as I'll come up with, you could ask him to print it out or type it out for you. So the other problem is language. So we should be speaking in plain English, or at least at a level that our patients can understand, because medical language, the number of words we learned in the first year of medical school are enough to constitute an entire new language. And it's very descriptive language, very precise with Latin and Greek roots, but it can sound like Greek to the average person that isn't familiar with medical terminology. So if we use a word that you don't understand, please don't be shy and please ask us to write it down for you. But on second thought, you should ask the doctor to print it out, knowing that a lot of us don't have very neat handwriting. So ask your doctor to print it out if you want to be clear. And when we prescribe something or when we recommend the treatment, even if it's something like a barium X-ray, colonoscopy, any prescription that we write, or any other type of treatment, there's 4 key things that we should be covering with you. And if you don't have these things covered, do ask about them, because this is very important for good healthcare and to make sure that we're looking after you and getting your informed consent. So these are really crucial. Number 1 is, we call it in medical terminology, indication. What is this drug or treatment or investigation for? What is it for? So we shouldn't write any prescription to you, and you shouldn't fill any prescription unless you know exactly what it's supposed to be treating. So that's number 1. But you'd be surprised on patients taking 3 or more medications that they kind of lose track of what drug is for what condition. And the second big question is, what are the common risks or the common side effects of this treatment or medication? For example, I might prescribe amoxicillin for a strep tonsillitis, bacterial infection of the throat. I would explain that the amoxicillin, it's a slight possibility of allergic reaction. So if you get any hives or itching or shortness of breath, that to stop it and to contact us right away. But other common side effects or risks of antibiotics could be yeast infections, upset stomach, gas, diarrhea. So those are common side effects that we need to explain to our patients. And of course, the major risk would be severe allergic reactions. And then the last important thing, what are the alternatives? Well, your choice, is there another antibiotic we can use as another way of treating this infection? And if we don't treat this infection, what could happen? So something like a strep throat is fairly straightforward, but it's important if we prescribe an antibiotic and you've never taken it before, that we do cover the common side effects, the major things that you would need to contact for, and also what the alternatives would be. Another example would be if an orthopedic surgeon is recommending surgery for your knee injury. So you need to know the name of the procedure and the technical name of the procedure. It's really important if you want to do a Google search and learn more information. So often patients have procedures but don't remember or don't know the exact name of the procedure. And you need to know what it's designed to do. Is it a knee replacement for severe arthritis? Is it arthroscopic surgery through a small camera to remove or repair a damaged meniscus or a piece of cartilage in your knee? What are the common risks of that procedure? So what are the risks of the anesthesia for having the procedure? Risk to respiratory problems or side effects from the medications, the risk for infections and bleeding. And what are the really major risks? The risk of a severe reaction or loss of a limb or severe bleeding that might need transfusions. And what are the alternatives? If I don't have the surgery, are there other ways that I can manage my arthritis of the knee, like with injections, with braces? What else can I do if I don't have the surgery? So this is the 4 key things you should know for anything that we would recommend: a treatment, an investigation, any type of surgery, and any type of medication. What is it for? What are the common side effects I need to know? What are the major ones I would want to know? And are there some alternatives? So you can weigh the risks and benefits of alternatives with the recommended treatment. In the very end, it's your decision, but we have to provide the information in language that you understand, not just medical language, so that you can make that informed choice. So the key details you should know for every drug, in addition for what we just described, were: number 1, what is it for? You also should know if there's any serious interactions with food or other drugs. For example, one of the traditional medications for high cholesterol to prevent heart disease or reduce strokes is it called a statin, and some of the statins interact with foods such as grapefruit, and that can lead to dangerous levels of the drug because they're metabolized in the same enzyme in the liver. So you need to know if food is going to interact with your medication. And also, some medications need to be taken on an empty stomach. An example would be a medication that we take for osteoporosis. It's taken by mouth, but it has to be taken on an empty stomach, at least an hour away from food with lots of water. But it has to also be taken at least half an hour before we go to bed, so we don't get a lot of heartburn or reflux. And a lot of patients don't know the names of their drugs. So there's 2 names: the brand name of the drug, and that could be like Crestor for rosuvastatin, that's one of the cholesterol-lowering medications, or Lipitor for atorvastatin, which is another cholesterol-lowering medication. Adalat is a brand name for nifedipine, which is the generic or no-name brand. So there's a brand name and there's the generic name, the chemical name. So you should try to learn both names. The brand name, some people just remember the first 3 letters of their drug, and that's often the generic company that's making that drug. So that doesn't actually tell us what the drug is. So if you only remember Tiva at the beginning of your prefix, or APO, the doctor won't know what drug it is. They'll only know it's made by that manufacturing company. So a lot of your generic drugs are produced by a drug company called Apotex, and Apo will be the prefix for that drug. So you should have on paper written out the full name, chemical name of the drug, the generic name. And if you're using a particular brand, it's useful to know that as well. So what is it for? What does it interact with? Other drugs or food? The brand name and the generic name. And you also need to know what the dose is. And that's not just one pill, but what size is that pill? How many milligrams? And we also need to know how often you're taking it or the frequency, as it could be just at bedtime, it could be in the morning, it could be with meals, or it could be twice daily. So those are the key things to know about your drugs. And sometimes it's best to have that in writing, so to have that on a list from your doctor or from your pharmacy. So what is the drug for? You should know what condition it's treating: high blood pressure, high cholesterol, or an antibiotic for an infection. What could it potentially interact with that you need to know? The brand name and the generic or chemical name, and the dose and the frequency that you're taking it. So that's really important to have a list in case you run out of medications, you're traveling, and you need to identify that to a physician in another city or another province. So these are 3 key questions that I kind of coach people. If you're ever in an emergency, a walk-in clinic, or traveling and have to see another physician, nurse practitioner, healthcare provider, they may not know you the way that your own family doctor knows you. And if you're worried that the doctor may be jumping to conclusions or making the wrong diagnosis, these are 3 questions that you can gently kind of coax the doctor to open his or her mind to make sure it's not something else. Because all the time that you're talking to us in the office, we're calculating in our head what this problem could be when you're giving all the symptoms. So when you give a history of an injury or abdominal pain, what makes it better, what makes it worse, when did it start? We're coming out with what we call a differential diagnosis, all the different things that it could be. And then when we're excluding and including certain things in the history, and then observing different things on examining you, we're kind of ruling in and ruling out different conditions. And we make mistakes if we're narrowing down too quickly to a single diagnosis when it still could be multiple other things. So sometimes we might funnel down too quickly if we're in a rush, or if we're not listening closely, or if we're not asking the right questions. That's why we do ask a lot of questions even after you've given a pretty thorough history, just so we can fine tune what the correct diagnosis could be. So a good awakening question, if you're not sure, is once the doctor feels he or she has a diagnosis and knows what's going on, you could ask, what else could it be, doctor? That gives us an opportunity to just think back and see, is there something I'm not considering, or there's something that could be very similar? And the second question you can ask is, what's the worst thing it could be? Like, could it be cancer? Could it be a heart attack? Could it be something that's really dangerous to my health? And then finally, once we come up with a treatment plan or a recommendation or a surgery or a drug, you could ask, what would you recommend if I was your mother or father or kid or best friend? And that just reminds the physician to think like we normally think in our office, is to think of the patient as you would as a close friend or a family member that you like. But one proviso with that golden rule, fortunately, my staff and I get along with all our family members. But if your family members argue a lot, then maybe it's not best to treat every patient like a family member. So these are 3 questions, and don't be shy to ask. Actually, after one of my patients attended one of my talks, I guess it was as a joke, he asked me, doctor, what's the worst thing this could be? But that helps us open things up so we think outside the differential diagnosis and make sure that we're not jumping to conclusions. Because we're trained to think of the worst case scenarios. Are we ruling out the most important thing? What are the red flags in what we're finding on the examination? Have we ruled out the most important dangerous things before we've started treatment? And I'll give an example. About 20 years ago, my patient had a colonoscopy. And when she was finished the colonoscopy, she was told everything was fine. But when she was there, she told the nurse in recovery, by the way, it wasn't Burnaby Hospital, and it was many years ago. She told the nurse that she had a little bit of a sore throat, that she felt a little bit short of breath. but she didn't look unwell and her vitals were still fine. So the nurse didn't think much of it and said, well, call your doctor if it's getting worse. It was getting worse, so she actually went to the emergency department with a sore throat because it was much worse. So it was quite painful around her throat. So she was seen by the emerge doctor, again, not Burnaby Hospital, and they looked at her throat. They didn't really see too much, but from her description, they thought it was probably a throat infection and gave her some antibiotics because that's probably the most common kind of sore throat other than a cold or virus. And then she came to me the next day actually feeling a lot worse, a little bit more tired and short of breath, and the sore throat had gotten worse. So when I was examining her, I knew that she just had a colonoscopy, and I had in mind what one of the worst case scenarios could be with a colonoscopy. So when I was carefully examining her feeling around her neck, I felt that there was soreness, but also the feeling of bubbles underneath her skin. And I found that actually it tracked all the way down her chest and her abdomen. So what had happened in the colonoscopy is one of the worst things that can happen. It's very rare, but that's perforation of the bowel. So air had leaked out and she had what we call subcutaneous emphysema. So that's actually air that's released from perforated intestine that had leaked underneath her skin, had tracked up and was irritating her throat. So I called another surgeon that was on call that I'm familiar with, and then he saw the patient immediately. We thought we had to, and she had a portion of her bowel removed, and she survived and she's totally happy. But that's because we were listening a little bit more carefully, and we were thinking about what's the worst complication she can have that can cause similar symptoms and looking for the signs. So it's helpful for all of us to think about as physicians, and it's helpful for you to remind us if we might seem to be jumping to conclusions. And this is all the more important when we're doing virtual health, where a lot of what we're doing is by telephone. So if you've had multiple calls with the clinic, with a physician, and what you have doesn't seem to be getting better, it probably is time to come in and do a careful examination with our face masks and being careful and keeping physical distancing and isolating patients from others in the same airspace. But to do that careful exam if things aren't getting better. Now, finally, doctor's orders. So I never call them doctor's orders anymore because that's actually coming from the wrong direction. We can have recommendations, but ultimately it's up to you as an individual and patient to choose what to do. We need to give you the information on what's important for what we feel to be for your health, but you have the priorities of your own life, and we need to be supporting you in achieving your goals. So I'm going to give you some tips on how we can achieve goals together. So number one, it's really important to choose the goal that matters to you. Like, choose wisely. I think that's number one. It has to be important and relevant to you. And you have to choose a goal that you have some confidence you can follow through with. So I'll give some tips on choosing the right kind of goals. So choose wisely, choose something that matters to you. And it's really important to visualize yourself having achieved that goal already. So seeing yourself as being successful, it kind of primes the pump for success, and it helps some of that negative self-talk. So if your goal is to quit smoking, for example, you actually have to visualize and see yourself in the near future as a non-smoker and how good you will feel and how much more vigorous and more energy you have and how much richer you'll be for not buying cigarettes. And that sense of accomplishment that you would feel, to really visualize that. And that's to kind of cancel out that condition programming of seeing yourself as not being able to make a change. And it's important to break down any goal from a mountain to a molehill. It's really great to have a great goal going from no exercise to doing the sun run in April. But if you haven't even been going for a daily walk, that could be a huge mountain that you may not even have the desire to start because it seems so enormous. But if we break it down into little steps, like just starting to walk every day for a given amount of time, 30 minutes, 5 days a week. And from that, when we gain confidence, start a walk run program or a walk jog program, walking for 2 minutes and then jogging for a minute, and then gradually increasing your jogging time. So to sit down with your doctor or other coach who knows you well, and to draw out a nice stepwise approach, beginning with a molehill that you can easily accomplish. Gain confidence and build upon that. So break down that mountain into a molehill. Write down the details. So it sounds like a little extra work, but when we write down our goals, we're much more likely to achieve them. And you may have heard of SMART goals. I believe it came out of 3M, one of the manufacturing companies. But of course, in Burnaby, we use the SMART test goals. So these are just a mnemonic to help remember the key things about any goal that you're setting up. So S is for specific. So you want to be more specific than just saying, I want to eat better, or I want to exercise more. What exactly are you going to do? What exactly are you going to eat better? So are you going to start cycling? Are you going to start going for a walk every day? And then where are you going to do that? Where specifically do you plan to do it? So that gives you something really concrete that you can start with. Otherwise, just getting more fit is a big lofty goal. M is for measurable. So how much, how long, how frequently? So if you're going to go for a walk, how long are you going to walk? How many blocks or miles or how many minutes? A is for achievable. So again, break it down into smaller bites. So it's realistic that you'll be able to do it in the next week. So really doable. R is it has to be relevant. Again, it has to be something important to you and your health and your priorities. T is for time bound. So when are you going to start? Rather than I'm going to do it someday or next month, what day are you going to start? And when will you finish? And then reevaluate, have you done? And then where are you going to go next? How are you going to make it easier? What did you learn when you evaluated? And then S is for stepping forward. What are you going to do next? So you're going to build upon your success that you managed to go for a 30-minute walk 5 days a week so far. So what do you want to do next week? Are you going to increase it to an hour? Or even better, T is for team. Who do you want to invite along to do this task together or to make it more fun? Or who can you work with to make you even more successful? So these are the keys to the smartest goals, ones that we can make more achievable. So it's a path towards constant improvement, starting with what's easy and doable, but something that really matters, being very specific, reevaluating how we're doing, and always improving on what we're doing and learning from that. It's really important to anticipate and prepare for a roadblock. So you might visualize yourself going for a walk every day, but you might visualize a sunny day. And if it's been a week like the past 2 weeks, are you prepared to walk in the rain? What are you going to do in the rain? Are you going to walk somewhere else, like in the malls, and then worry about COVID? Or are you going to put on a nice, bright yellow raincoat and umbrellas and walk on a safe path far from the road and the splashes and puddles? So anticipate and prepare for those roadblocks. And number 6 is to enlist support. And that could be us as your primary care providers, your family doctors. It could be a coach if you're starting a running program, or someone to do something with. Like maybe your activity might be to go cycling with a friend or with your partner, going for walks together. So having someone else to achieve a goal with or to report to also greatly increases our chance for success. Because we get used to disappointing ourselves and not following through, but we're less likely to disappoint other people that are rooting for us, and they can offer a lot of encouragement as well. So I also wanted to go over a lot of the things that many of you may have missed in the past year and a half if you haven't seen your doctor in person. So I have in my office a list of screening tests as reminders for patients. What tests do adults need at different times depending on their gender? So based on age and gender. And screening tests are those things that we do periodically. Some of them are every year, some of them are every 3 years, and some of them are only at a particular age. So the most important thing is that screening tests are done on the general public who are not having symptoms for these medical conditions, and designed to detect these conditions early while they're treatable. And so it's for people with average risk without any symptoms at all. For example, screening for diabetes. So if you have a high risk for diabetes, then the timing of these screening tests is totally different. And if you have a family history of breast cancer at a young age, the timing of when we start screening mammograms is completely different as well. And if you have a family history of colon cancer, you're not going to wait to age 50 until you start screening. You would actually start 10 years before the first relative was diagnosed with colon polyps or colon cancer. So that's something that's best to discuss with your family doctor. A good question you may ask your doctor, just to remind them about what tests you're due for, is asking your doctor, even if you're there for some other reasons on your list, you can ask, at my age and with my past history and family history, what tests am I due for? So that's a good, simple question to ask. So at my age and with my past medical history and my family history, what tests should I be doing? And that's a good reminder for the physician when they're dealing with the task at hand, that we're looking at the big picture of preventive health and early detection. The number one, screening for high blood pressure. So the general rule, the guideline, is that every adult over age 18 should get their blood pressure checked at every appropriate medical visit. So roughly annually. But of course, most of you haven't seen a physician for the last year or year and a half. And when you do see physicians in the office, time is even more limited because we don't want usually more than a 15-minute exposure to each other in an enclosed room, because we know that even though we're double vaccinated, there's still a chance of contracting a lesser case of COVID and spreading it to others. So we're still wearing our face masks, but still trying to avoid prolonged visits with multiple people in the same room. And of course, so it's been quite challenging for people to keep up with their blood pressure, but that's something we are trying to do again. And a lot of my patients that do have hypertension or a family history of high blood pressure, or we've been monitoring their pressure and maybe even before they require any medical treatment. I've asked lots of patients to get blood pressure machines so that they can monitor their home blood pressure. In fact, that's one of the mainstays for treating blood pressure, even on medication, because we do know that home blood pressures are usually more reflective of the goals rather than the pressure in the hospital or in a medical clinic, where it tends to be at least 5 millimeters higher. So even those of our patients taking medication for blood pressure, when we check it in the office, I do ask most of them to consider having a reliable home blood pressure machine. And I do ask them to drop it off at different times so we can just check to make sure it's very close to our standard instruments that are calibrated here. So do ask your doctor if you're due for a blood pressure check, so that could be done. You might notice that most pharmacies have gotten rid of the blood pressure machines. Be cautious if you do find one there, and make sure that it's been cleaned if you decide to use it, just because that could be a possibility of contamination during the pandemic. So screening for cervical cancer in women, the pap smear, it's not the same thing as a pelvic exam. So a pelvic exam is when doctors use an instrument called a speculum to look inside the vagina, look at the cervix. The pap smear is actually a sample taken from the cervix that's done during a pelvic exam. So it's really important if a woman is getting a pelvic exam to know what swabs are being taken, what the doctor sees and finds, and whether or not a pap smear was taken at that time. So I try to clarify with patients if we're doing a pap smear at the same time, because they might be getting a pelvic exam because of symptoms or an infection. And we wouldn't necessarily do a pap smear if they're actually not due for it, like if it's too early or if they're too young. So it starts at age 25 and extends to age 70. And generally when pap smears have been normal, we get a recommendation from the cancer agency that keeps a log of every woman's pap smears in the province. So it's now every 3 years. And in previous years, it used to be every 2 years. But now the standard is every 3 years. Women over 70 years of age could stop screening if they've had 3 successive normal pap smears in the past 10 years. So that's a great relief to a lot of my patients over age 70. But just remember, even if you no longer require the pap smears for these reasons, if you have any postmenopausal bleeding from the vagina or pain in that area or unusual discharge, it's really important to talk to your doctor and have a proper examination. The cancer agency interprets the pap smears. It usually takes them a month or so to receive them, interpret it underneath a microscope, and then they give us advice whether or not this is fine and it could be done in another 3 years, or if it should be done more frequently, usually no more frequently than every 6 months until any abnormalities return to normal. So sometimes we'll get recommendations for 6 months, 12 months, or 24 months from the cancer agency, depending on the history and the appearance of the pap smear. But when they've been normal, it's every 3 years. So the screening mammogram is now recommended in general for women age 50 to 70 years of age, every 2 years. So 10 years ago was quite different. We started screening at age 40 and did it every year until age 50 and then every 2 years. The recommendations changed because they felt that they were getting a lot of false diagnoses between age 40 and 50. But the program is open to women starting at age 40. So if you're 40 and over, but not quite 50, and you're not sure if you should start mammograms, it's important to discuss it with your family physician so they can review your personal risks, tell you what to watch out for, and to review your family history to see if you're someone that should be starting it earlier than age 50. And if there's, of course, as I mentioned, this is for women of average risk. If there's family history of breast cancer, it's important that you talk to your doctor to determine when's the best time and best way to screen with a mammogram. So women usually get a copy of the report sent to them when they do a screening mammogram. And in recent years, they've been discussing the breast density rated from A to D. D is the most dense, A is not dense at all. And when breasts are very dense, it's harder for them to interpret a mammogram. So you need to keep in mind that if you have increased density of your breasts, even if the mammogram is normal, if you were to feel anything that felt like a lump or pain or change in the skin in the breast, that you seek the attention of your physician to see if you require something in addition, like a diagnostic mammogram. There's different viewing screens that they would use so they can take a closer look and pinpoint an area of concern. And sometimes that's done in conjunction with an ultrasound. An ultrasound is not a substitute for a mammogram. So it has to be dependent on the patient's condition and the scenario. So you'll see a rating if you do get a mammogram report, the BI-RADS density from A to D. And how do we screen for colon cancer? So this is one of the most preventable cancers because on average, it takes 10 years from the appearance of a polyp until it develops into a cancer in general. So the general rule is we start screening adults at age 50 with the stool occult blood test. So it's actually a little tiny kit, smaller than a credit card that you actually take home. And it only needs a small amount of stool to be put on it with preparation and then returning it to the lab in a sealed bag and envelope. So it's not a sample you don't need to be prepared to have a bowel movement at the lab because that would take a lot of self-control. But it's one of the things we add on if you're over age 50. Every 2 to 3 years, but now the cancer agency has set up a recall every 2 years. So some of you may have got a notice from the cancer agency saying your last fit test of 2 years ago was fine, but here's a new requisition so you can go into the lab and do another one. So a lot of patients just read one side and not realize that on the other side of the page is actually the requisition. So take a careful look at both sides of the page if it's printed double-sided. You may know there's an alternative screening technique, which is a bit more invasive, called the colonoscopy. And that's where specialists will insert a flexible scope into the anus after a day of bowel preparation to empty out all stool. And that little camera snakes up the entire large intestine, up to the left side, upper abdomen, down the right side, all the way to the cecum, which is close to the appendix. So that's usually a procedure that's done, booked ahead of time in the hospital. Now, they haven't set up our system in BC or most of Canada to do colonoscopies every 10 years. And some people with some hospital programs or insurance programs in the States, they have programs like this that they do a colonoscopy every 10 years. So, so we settled here to do the FIT test every 2 years. But if you have blood in your stool and you're close to age 50, or if you have family history of colon cancer or colon polyps in your mother or father or a sibling, it's important you talk to your doctor to see if you should be referred for a screening colonoscopy at a particular age, younger than 50, if you have family history of colon cancer polyps. But if you have symptoms and you're getting in that older age group, the doctor will examine you and determine if you should be seeing a specialist to do a colonoscopy. So if you have symptoms, like with all screening tests, don't follow these rules. Speak to a doctor to see what tests should be done right now. And how do you screen for prostate cancer? So I'm sure the majority of you male patients over 50 probably haven't had a screen for prostate cancer. So the gold standard is the digital rectal exam, which unfortunately cannot be done on a computer. Digital refers to my finger with a glove. And generally men over 50 years, about every year, it's a good idea to do the digital rectal exam. Of course, there's an alternative way of screening, but it's not recommended as a routine screen. It's the prostate-specific antigen blood test. So generally, PSA is a protein that's produced by the prostate. So there'll be some level that's normal for your age or for the size of the prostate. So if you do a PSA test and you're 80 years old, your prostate will be gradually growing as you get older. It's about this size when you're a teenager, about this size when you're 80, and somewhere in between if you're about 50. And the prostate is very close to the neck of the bladder. So as it gets bigger, it makes it harder to urinate. So that's why there's a good strong stream in young men, and older men are spending a longer time in the washroom standing up, and sometimes with dribbling and having to go back after half an hour. So those are not indications necessarily of prostate cancer, but benign enlargement of the prostate that most of us will go through as we get older. So the PSA will gradually go up with benign enlargement of the prostate for most men, but it can go up very high and very rapidly with prostate cancer. So for some, you speak to your doctor to see what's the best way to screen for prostate cancer if you're getting close to 50 with no family history of prostate cancer. If you do have a family history of prostate cancer, do speak to your doctor about when you should start screening and which way you should start screening, what symptoms you should be watching for. Because you don't want to be 80 years old and do a PSA test and then find that you have a very early prostate cancer and then do a lot of surgery that can affect your continence and bladder control when it's a very slow growing cancer that may or may not cause a problem. So that's why it's quite controversial to do it as a screening test when you're older and don't have a really long life expectancy. So something to discuss with your physician, what's the best way to screen for prostate cancer? So I define health as the optimal balance of the important areas of your life. And it's based on your values and where you find meaning. And it really is the achievement of your positive potential in life. And so what I do is I've created this kind of mandala. So this is what I've been using for the past 20 years just to help balance my life, because as you can see, we have some very long days and a lot of emergencies and some stressful moments throughout each day. And medicine, like most professions and jobs, can consume as much time as we give it to. But there's always other important areas of your life that we need to balance on a regular basis rather than waiting until something goes wrong. So you can see at the top, we need to balance work with rest and play. We need to balance our social life with our time with family. And that's been quite I think some people have had an overdose of family that they're living with over the past 18 months and underdosing on the social interactions. But a lot of people have been isolated in their homes and not able to see their extended family because of the pandemic. So it's been a really tough time for everyone's mental health, but some of us have been struggling much more than others. So again, we're all responsible for our neighbors and one another. So reach out to your neighbors that are isolated or could need some assistance and companionship. We have to balance our physical well-being, exercise, and general physical well-being with our mental health, our emotional well-being. So both of these are really foundations of your self-care and topics for our Empowering Patients program. We need to balance our emotions with our environment and spiritual needs with our financial needs so that we can pay down the rent and pay the bills and have food on the table for our family. But sometimes we can get stuck and spend too much time at work, too much time preoccupied with financial problems and not attending to the other important areas that make you a complete and whole person. And at the center of all these things is to find your calling, your special purpose in life. So imagine achieving your positive potential. And really we're here as your healthcare providers to support you and to be your advocates and to listen to your needs and to guide you through the healthcare system and to guide you through life. And I'd like to remind you about some upcoming talks we have. So the next one I'm talking about is emotional well-being, November 25th. And I want to remind you that Leona has some links that are posted on the side for how to register for Empowering Patients programs in this coming up, how to get on the email list so that you get notified of upcoming talks and changes. There's valuable information about COVID. We actually have through our Burnaby divisions a COVID newsletter that we update every week with lots of interesting things and important information. She has links there for the current case counts and also how to get vaccinated if you have some questions about that, and how to obtain a vaccination card. So Leona has kindly put all those together for us. And just a reminder that healthcare is really self-care. You have to remember that in our office and in most family practice offices, we really have a strong relationship and a really deep caring for our patients. And we do miss you, not seeing you in person. So it was kind of nice with our first flu shot clinic with my patients yesterday. I got to see 40 of our patients spaced out, wearing masks, and actually seeing them in person and poking them in the arm. So we see our patients as like our best friends and family members, especially our friends and family members that we love the most. Leona, are there some questions in the chat? And if you have questions, please enter them in the chat, and then I'll ask Leona to read them out to me, and I'll try to answer any questions about what I've talked about. If you want to share any questions or your own observations about your own patient-doctor relationship.
Sure. Okay. The first question is from Ellen. She'd like to know if she should take the third shot for COVID-19.
That depends. I assume you're over 12. I would say yes. All the information says yes, you've done well with the first 2 shots, but if you've had some side effects or problems and not sure about the safety issues, you should talk to your family doctor about it, because I can't really give you specific advice. But in general, most adults, unless they have a severe allergic reaction to one of those first 2 shots, should get a third dose when it becomes available. So I'm waiting till I get a chance to get my third dose. I think only my colleagues that are working in long-term care have received it. Yeah, because I know our Burnaby division chair was on Facebook and showed that he was getting another shot. So I think he got his a couple of days ago. So I assume that's because of long-term care. The rest of us are waiting right now. So they've been working on seniors in long-term care facilities because they're at higher risk, because we've seen that there's some breakthrough cases that our immunity starts to wane, possibly around 6 months after the last shot. So I think we'll all be coming due soon. And on a similar note, I went to a movie theater for the first time because there was half capacity. So we went to the Landmark with my wife and we saw James Bond, and they were checking to make sure we had our vaccination. They were checking it at the New West Landmark, and it felt super safe. We were wearing our masks throughout, but super spaced out. There were only 2 people in our row, really far away. And the row behind us was empty. So we were super distanced from everyone. So it felt really safe. I do have a little concern about going into a theater, which is, as of Saturday, theaters could be 100% capacity. So I don't think I'll be seeing another movie unless I can get in to see the next Marvel movie with my wife on Friday or Saturday. So keep in mind, I'm a bit concerned that not everyone is going to be getting their third shot and to have their full immunity or best possible immunity when things are getting busy again. So to be cautious about getting into crowded gatherings, because sports events and other things are going to be full capacity on Sunday in BC. So there's a long answer, but I also always had so much more to say.
It was a good one. Ellen, I hope that answered your question. The next one is from Celine. She said that her mom had to be admitted to long-term care in Burnaby, and they were told that she would no longer be seeing her own family doctor, and her medical file was transferred to the nursing home. Is that normal practice?
It is pretty normal practice now, because if a long-term care facility is quite a long distance, like another city, it's really impossible for your family doctor to make visits to that long-term care facility. But also in family practice, like I'm one of the last, I think they call us dinosaurs now. So one of the last that still does deliveries at the hospital, still does palliative care if my patient gets cancer and needs care at home. So I work with a home care nurse doing palliative care and doing house calls if we need to do house calls, and the nursing home. But a lot of family physicians, most of them don't do their deliveries anymore. And I will always consider it year by year because we do need our sleep the older we get. And there's a dedicated group of family doctors that do residential care as a major part of their practice. And each residential care facility actually has a group of house doctors. So there might be 80% of the patients in a facility might be looked after by a small number of physicians that do regular rounds. So that's actually the most common thing, is that if you transfer to a long-term care facility, chances are your family doctor won't be able to follow you in that long-term care facility. When my patients go to a long-term care facility, sometimes in Burnaby, they sometimes give us the option if we would like to continue. If the patient is in another city, like a lot of my patients are in Surrey or Delta or even Maple Ridge, that would be quite impossible to continue seeing them in a timely fashion if they need to be seen in person.
Okay, thank you. Next question is from Celine. If I am referred to a specialist and the doctor is a bit dismissive, is it advisable to ask my family doctor to refer me to a different specialist?
It's, I think you should talk to your family doctor about the results of the consultation. Sometimes the pickings are slim with some specialties, and as family physicians, we sometimes we know that some of our colleagues might have a brusque manner, but we still trust them because there's a dermatologist, once now retired, and he was getting a bit older, and he was always quite gruff with patients, but I always trusted his judgment. So I kind of braced patients sometimes that he might seem really gruff, but he's never been wrong about diagnosing a skin cancer, and his advice regarding treatments have always been spot on. So this is someone that I would refer my family to, and I have. So to keep that in mind, we're seeing this specialist for their expertise and their opinion, but of course, if they're not listening to you, or you feel they've made the wrong diagnosis, or weren't listening to you, or answering those key questions that we talked about risks, benefits, alternatives, common side effects and extreme side effects of what they propose, or what the other diagnoses could be. That's really important information that any specialist, no matter what their bedside manner might be, that's important for us to address. So I think it's appropriate to talk to your family doctor. There's not always a great fit. Really important to have a great fit if you're seeing a counselor, so that you have some comfort with them. But sometimes we don't have a lot of choice with some really super specialties. But it's important to talk to your doctor about how the outcome was, and to go over the recommendations from that doctor to make sure that you get the best care you deserve to have.
Great, thank you. Craig would like to know how important it is to get the current flu shot, not the COVID-19, but the current flu shot.
Well, we're being told, and I would agree, that our risk for the flu is probably much higher than it was last year. So we were really lucky last year because we were all wearing masks, physically distancing, because we didn't have any vaccines at that time. And then we actually had very few flu cases at all. And there was a big turnout for flu vaccines last year. And they predict that because we haven't been exposed to the flu virus over the past 2 years, that we're likely to be more susceptible. And that's really more important to get the flu shot this year. And that's why the government has actually opened things up for anyone that wants a flu shot, that it is fully covered. Because in the past, there were some restrictions that you had to be 65 and over, or be at higher risk because of what you do, where you work, such as healthcare, or if you had other health conditions, or be around people that are at high risk. But now they've lifted those. So for the first time ever, they said that anyone that wants a flu shot will be covered to have a flu shot without having to pay privately. So the government has indicated, and all the information that we see says that it is important to get the flu shot. A lot of people try to kind of guess that what if the flu season is actually later? Well, if they get the flu shot too early, will they miss out and not be immune in the springtime? Well, that's always a bit of a gamble, but here we are at the end of October. This is usually the optimal time to get the flu shot. So if you have the opportunity, do get it when you can at your family doctor's office or with your local pharmacy.
Great. And the follow-up to that is, what type of flu or viruses is the current flu shot inoculating us against?
I'm not prepared to say that because I don't have the list in front of me. But they're quadrivalent, and it's based on what they suspect over what's happening in the Southern Hemisphere. So it's always an educated guess, and it's the best mix that they can think of. And there's slight variance in what's in each of the flu shots, but it's I believe it's the quadrivalent with 4 different strains that they predict will be the big ones this year. And as you know, they sometimes guess wrong, but there's no way of knowing. We just have to rely on the experts for that.
Right, great. Celine would like to know if you've been to seek medical help in emergency, is it advisable to contact your family doctor and do a follow-up?
Most of the time it is, and usually the emerge doctor will ask you to follow up with your family doctor. So that's why it's so important to request the same information that we gave you. And by the way, there's a key points handout that you should print out or keep on your phone, so that if you do go to the emergency, to make sure all your questions are answered. So it's really important to really be clear about, well, what happens next, and what tests need to be done. Should I follow up with my family doctor, or am I supposed to see a specialist? So that's really important to have that clear plan after. And it's important to have that clear plan at the end of the visit as well with your family doctor. So in general, yes. Also make sure when you go to the hospital, they always ask, who is your family doctor? So make sure they have the right family doctor on record. because we generally do get a messy handwritten report that we can't read, but sometimes we get something typed out that we can read from the emergency department.
Great. So Mary was just, I think you covered this, Dr. Wong, but what is the procedure for obtaining a third shot? Will we be advised when it's time, or do we have to register?
I think we're going to be advised when it's time, when we're allowed to register. So I believe
Ellen
that-
has commented that she has received notification for the third shot. So
great.
that's helpful too. Okay. Anna is, I think you might have touched on this as well. Do you feel it is safe to attend events such as hockey games now that they will be at full capacity?
I'm not going. If I do go, I force myself to wear a N95 mask. So that the highest grade of medical mask. Because as we know, the immunity might be waning, and we know that people are going to be double vaccinated to get into those events. But unless we get our third dose in a timely fashion, I'd be a little bit concerned. So if we roll out and get all our third doses at the right time, I think probably would be safe after another month or so. But if you're just about due or overdue and you haven't been called and you haven't been able to book yet, I would make sure you get your third dose before you consider going to the events that are at full capacity.
Okay, great.
But that's my opinion and not the opinion of Ministry of Health at this time.
Great. So Ellen is asking, should I take the flu shot first before the third COVID shot, or does it matter?
They're telling us that it doesn't matter, that COVID shots can be taken the same time as the flu shot or close together. In other major vaccines, we usually try to space them a month apart, like the shingles vaccine. But in general, the flu shots, it's actually, I don't think it really matters because we're allowed to give them both at the same time if the opportunity arises.
Okay.
So that's what the CDC has said.
Great. I think that's it. Unless anybody else has any questions, we've covered all the ones that are in the chat.
There's one thing I promised that was really important with people talking about going to the emergency or other doctors, and that's the key medical information you should have. So I don't remember if I popped up that slide. So it's the key things you should know if you go into an emergency or go to a walk-in clinic. So this is like a one-pager of the key things that you should know about your medical history. And if you're unable to do that by heart, then you should ask your doctor to help you complete it at some point. And we actually have that. We actually have that as part of our medical record. So the important thing is you need to know what your important allergies are. So what are you allergic to? And usually that's to drug allergies or with latex. So that's really important to know your allergies and to have them listed and written out. And if you're not sure, ask your doctor, ask your pharmacist what you have on record. Number one is allergies, because a lot of things we can prescribe or give to you, or even the latex on our gloves can cause allergic reactions to the susceptible. Number two is you should know your family history. You should know causes of death or major illnesses in mother and father and grandparents and siblings. Important things would be history of diabetes, high blood pressure, heart disease, and strokes or cancers. So important to know your family history because we do a different level of screening for those conditions at people at higher risk. And it also changes what we think about what's the worst thing it'd be when you have a presenting problem. The third most important thing is your past medical history, like significant illnesses that you have when you had to be hospitalized and staying in the hospital besides emergency visits, broken bones, and what operations you've had. And really for this, you should have the medical term for your operation. So gallbladder surgery is called a cholecystectomy. And we have complicated names for different surgical procedures. It's important to have that in writing, what procedure you had. So your past medical history, important hospitalizations and operations that you've had. Your chronic medical conditions. Those are the things you're diagnosed with this and you always have it and you're managing it with your doctor, like diabetes or angina or heart disease or cerebrovascular disease or kidney function disease, like renal failure, asthma, chronic lung disease, heart failure, all these chronic conditions, they should be part of your one-pager medical history. And of course, the list of your medications, brand name as well as generic name, and those little details that I mentioned about what you know about a drug, the milligram dose, and how often you're taking it, and what you're taking it for. So that's really key information you should have at your fingertips, and probably best on your phone or a one pager that you fold up and keep in your wallet, so that if you do end up at a walk-in clinic or emergency, that you could just show it to people and they have your history at your fingertips. Because even though we're all using computers, our computers are not necessarily sharing all the same information with each other. So that's important that you should have on your person and really understand it. And if you have difficulty listing it out, do ask your doctor. We may not be able to print it out on the spot, but they can prepare something for you and send it to you or have it for you so you can pick it up. So that's the one pager that has your allergies, your past medical history, your family history, your list of medications. And as we get older, you should think about advanced directives. If, say, you're quite elderly or have heart disease, do you want to be resuscitated if you have a cardiac or respiratory arrest? Do you want CPR, defibrillation? So that's called a do not resuscitate or full code order. And there's other levels of that as well to decide if you would want to be in an ICU or a CCU or full medical care, or you would just stay at a long-term care facility to get your needs met as well.
Great. Angela's put her hand up. I was going to unmute you, Angela, if you have a question for Dr. Wong.
No, really, but I think all these questions has been answered. It's pretty good.
Okay.
Thank
Thanks,
you
Angela.
so much.
Thanks for joining.
Yes, really. Yes.
No problem.
Thank you.
Great. Thanks, Angela. So Craig has said it's just been announced by Vancouver Coastal that there's been a hepatitis A exposure event at a restaurant in Whistler last weekend. He was not there. And there's a Hep A vaccination clinic being held tomorrow and this weekend in Whistler. When is it a good time to get a Hep A vaccination?
Hepatitis, well, thanks, Craig. So Craig is a reporter. Craig McCullough is a reporter. I'm sure that's Craig McCullough. So he's always up to date in the latest. So thanks for that. Hepatitis update. So hepatitis A is a type of hepatitis you could pick up from contaminated water or food. So if you're a traveler, and I don't think any of us are, especially the third world during the pandemic, depending on where you're traveling, you might get a hepatitis A vaccine. That's the Havrix vaccine. But for most of us, we don't usually do hepatitis A vaccines as a routine screen. If your job is working as a plumber and you might get exposed to a lot of contaminated sewage, unplugging things for people during house calls, then you probably do that for prevention. But for most of us, we're not doing that in a routine way. So if you're getting that vaccine, you probably would do that a month away from a COVID vaccine. And it sounds like it's a priority for those that eat at that restaurant. So I guess Craig didn't tell us which restaurant in Whistler. I wasn't in Whistler eating at any restaurant, but so that would be from a restaurant worker who didn't wash their hands properly. So the importance of hand washing for all infectious diseases. So it's passed through stool contamination. So going for a poop in the washroom, not washing your hands, and handling food. I'd like to know the restaurant because I wouldn't go to that restaurant at any time, even when they're not having a hepatitis A outbreak.
The Splits Grill, never been.
Oh no, we love those burgers.
Oh no.
If they're not washing their hands when they're preparing food, then that's probably a higher risk of spreading COVID as well. Oh well, we didn't eat it at Splits Grill, but we're not going to go there anytime soon either.
Well, on that note, I think you've covered all of the questions. Just as a reminder from me, Dr. Wong, when we close out tonight's webinar, there will be a survey that'll pop up with just a few questions, and it helps Dr. Wong and I. Your feedback helps us as we plan upcoming events. So if you could take a moment and answer a few questions, that would be great.
Okay, thank you everyone for your time. I know there's lots of good TV shows on. Hopefully some of you have a PVR. Thanks for joining us, and I really appreciate your participation and really appreciate Leona. So we send a thank you to Leona for making this all possible for us.
Great. Thanks, everybody. You have a great night.
Good night.
Good night. Lovely thank yous in the chat. Take care, everybody.